should be able to access quality healthcare services they need regardless of their socio-economic circumstances. That is why we strongly support and advocate for the achievement of the universal health coverage, particularly through the implementation of the National Health Insurance or JKN program. We all know that universal health coverage provides an essential basis for sustainable and inclusive growth that we all aspire to achieve. Progress towards universal health coverage, which ensures that all people can access the quality health services they need without experiencing financial hardship, will improve people's health outcome. The improvement in health outcomes will help develop the human capital that we need in order to overcome the current challenges and achieve our common goal as a nation. As you may be aware, in order to support the creation of resilient and effective health system, the Ministry of Health has developed 6 pillars for health system transformation. The 6 pillars consist of, first, the transformation of primary services. Second, the transformation of referral services. Third, the transformation of the health resilience system. Fourth, the transformation of the health financing system. Fifth, the transformation of human resources. And last, sixth, the transformation of the health technology system. We are confident that through the necessary policies and measures that have been developed and implemented so far by the Ministry of Health, we will be in a better position. We will be in a better position to put people at the center of our health development and health system, mobilize necessary resources, both human and financial resources, particularly during public health response and emergencies. We will also be well placed to strengthen our primary health care as the foundation of our health system, expand the access to quality health care through the implementation of National Health Insurance Program or JKN, and ensure better engagement from both the public and private sector. In closing, I do hope that this webinar will contribute further to our collective efforts in strengthening our global health architecture through health system resilience under the Indonesian G20 presidency. Allow me to end my remarks now by wishing you all a successful and productive webinar. Thank you. Return to you, Mas Rizky.
Thank you, Mr. Kunta, for the remark. Ladies and gentlemen, before we are going to continue with the next remark, we would like to inform all participants that you may also follow the discussion by activating the live transcript feature, and hence you will have the auto caption on your screen. Ladies and gentlemen, up next to deliver the welcoming remarks is the expert staff of the Ministry of Finance for the State Expenditure, the Republic of Indonesia. Please welcome Mr. Made Arya Wijaya.
Okay, thank you, Mas Rizky. So, distinguished ladies and gentlemen, good evening, especially my colleague Pak Kunto, and also the chairs of Prof. Tabrani, the Indonesia Ikatan Ekonomi Kesehatan Indonesia, invite me. Please allow me to give the remark. It should be delivered by Mr. Sua, the Vice Minister of the Ministry of Finance. I think the title for this webinar is very, very important for us in Indonesia, especially since the situation right now, we're still in the pandemic COVID-19, and also how far the government in Indonesia especially respond to this pandemic. So in this occasion, let me share how the government of Indonesia experienced dealing with the COVID-19, at least the last 3 years until now. So if we look at the numbers of cases and also the effect of the COVID, we all aware that the economic growth getting worse the last 2 years. while now in the 2022, we start with the recovery period. So how the government Indonesia try to dealing with the COVID-19, at least the government define or set up the specific program. We call it the pandemic response and the national economic recovery, or we call it the PC-PAN, which is in the beginning, in the 2020, the government set up this program consists of 5 clusters. So the first priority is, of course, the health, and then the social protection, and also how the line ministry they prioritize the program to let's say create the job and also improve the society power of power of the transaction, and also support to the corporate, and also the incentive given by the government. So until now, if you look at the how much the budget provided by the government dealing with the health during the pandemic, at least until now, the last 3 years, we already put more than 300 trillions, especially right now in the 2022, in the health clusters, we provide the 122 trillion rupiah to dealing with the health cases, how to accelerate. We still conducting the testing, pricing, and also treatment, and how we accelerate the vaccination process, and also provide the health facilities, and also how we give the incentive to all doctors and paramedics during the work dealing with the COVID. So I think we need also input from the speakers, and also the how the surveys is conducting by WHO and also the World Bank, which give us a very positive input to dealing or how we design the program to recover our economic. So I think this webinar is very important to all of us in Indonesia to get some more inputs in preparing our next year budget for 2023. Of course, we still give the health as the first priorities. Besides, we also try to recover our national economy. So from the all topics, I try to read whether for day 1 and day 2, I think is very important and very, very useful for us, and hope the all participants can get knowledge and also new views how the global dealing with the health for the next future. Thank you, Mr. Rizky.
Thank you, Mr. Made, for the remark.
Yeah.
Ladies and gentlemen, today's webinar consists of 3 sessions. And right now, we are about to jump to the first one, which is an interactive session, namely setting the stage. What has been the key effects of COVID-19? And to lead this session is our moderator, who is the head leader of the Indonesian Public Health Association. Please welcome Mr. Ede Surya Darmawan.
Thank you very much, Mr. Rama. Distinguished Mr. Sekjen, Dr. Pita, and Mr. Made, thank you very much for your attendance.
Yeah.
Of course, Yustia Saminarsi for your attendance here. Ladies and gentlemen, if we take a look to about 20 years ago, WHO already proposed what's so-called the landmark or the structure of the health system. And WHO recommend what's so-called people at the center of the health system. But the question is, currently, almost 3 years, we are facing and changing situation because of COVID-19. So the topic, what is the effect of the COVID-19 to our health system? And it is the exact or the precise topic to be discussed, and will be delivered by Ibu Diah Satyani Saminarsi. Ibu Diah currently serves as a senior advisor on Gender and Youth to the WHO Director General. Also, the founder of board of the trustee of CISD, Center for Indonesia Strategic Development Initiative, the Jakarta-based a think tank working to alleviate health services delivery problems in Indonesia. Ms. Dia journey in Indonesia, her system funding began with design as implemented Pencerahan Nusantara, and an initiative that's serving the primary healthcare services in various rural locations in Indonesia. The initiative became a breakthrough innovation to trigger the systematic change in the Indonesian health sector. In 2014, after the appointment of Special Advisor for the Ministry of Health, Ms. Dia represented Indonesia in numerous global agenda, including the UN General Assembly on the concept of Sustainable Development Goal, SDGs, within the duration of 2020 and 2014 World Health Assembly, also commemorating the WHO Director General candidate debate, as well as Stockholm Food Forum 2017, where he presented Indonesian government plan in hosting the first Pacific Forum. So, without further ado, I'd like to welcome Ibu Dia Saminasi to deliver what is the effect of COVID to our health system. Please, your time about 10 minutes. Thank you.
Thank you. Thank you, Pak Ede. Greetings to you and to everyone, Pak Kunta, Pak Made, Mas Rizky, Prof. Hasbullah, ladies and gentlemen, distinguished panelists, and all the participants of this webinar. Good afternoon, good evening, and perhaps good morning to some of you. I would like to share my slides from here, just to make sure that everyone is get the clear and perfect view of this how to recover and the summary of the 2021 WHO Pulse Survey. I would like to bring our attention first to the situation prior to the pandemic, namely in 2017 and 2018, where WHO put forward and was approved by member states the 3 billion goal, in which WHO said, if we achieve this 3 billion goal, then 3 billion more lives can be saved. However, due to the pandemic, initially we take note that the countries report disruptions. 90% countries report disruptions in their essential health service, and the most impacted services are immunization, NCDs, family planning and reproductive health, and mental health. It occurs due to the decrease, 76% decrease in demand, and this is due to the constraint from the health workforce, the requirement to provide extra protection for the health workforce with PPEs, and also budget constraint. This situation of the pandemic jeopardized the achievement of this 3 billion goal, and WHO then conducted this global pulse survey beginning in 3 cycles, beginning in 2020 up to the last quarter of 2021, where the objective is to provide a rapid snapshot of changes and challenges in service delivery and utilization of services during the pandemic. So this is still ongoing. The pandemic is still going on. We are still in the pandemic, but the survey concluded in 3 rounds. And of course, it is also equipped with a modular approach where WHO have a in-depth consultation and discussion with different Ministry of Health informants. In the methodology from that survey and of that discussion, WHO finds 92% of countries, or 117 out of 127, reported some extent of disruption. And among these 92%, 45% reported a decrease in disruption or decrease in service. The comparison in 28 services in 91 countries who responded to all 3 rounds of the survey. So 91 countries responded to all 3 rounds of survey. And in round 1, 2, and 3, we can see this table here. The average disruption is 44% in 28 services in 91 countries. And it is interesting that only 11% of the countries report no disruption at all, while less than 25% disruption is reported in 21% of countries during the last round. It is a double value if compared to the first round where countries participated in and reported in round 1. Other than that, the numbers are more or less the same or almost the same. 75 to 100% of disruption reported, there is a decrease in countries that reported 75% to 100% disruption from 37% to 19% of countries. So we can assume perhaps that this is a good sign that there are recoveries made in a number of countries. The percentage of countries, among the percentage of countries reporting disruption, 53% reported disruption in its primary care, 38% in emergency and critical operative care, elective surgery 59%, rehabilitative services 52%, and community care 54%. I would like to underline that the community care and primary care is actually, they actually reside within the same ecosystem of primary healthcare. So disruption in community care and disruption in primary healthcare are actually a disruption in its health system in the primary healthcare system. Most service delivery settings experience similar disruptions level to early 2021. So if we can see here, the example is in emergency care. The last quarter of 2020, when the first round was conducted, was 21%, and quarter 4 2021, where the third rounds was conducted, the disruption was 36%. 40% countries reported increased backlogs in multiple essential health services during the second half of 2021, including care for those not only in primary healthcare, but also in the secondary care and tertiary care, most notably cancer and NCDs and rehabilitation. However, countries reported that they are taking actions to mitigate the consequences and they continue to promote service recovery with, among others, taking actions in these following areas: home-based care and catch-up visit, recruitment and training to support the health workers, procurement of search commodities, communications with communities, and a number of health financing strategies. So a combination of these actions are being taken by countries to mitigate the disruption that are still going on right now. Countries take note and actions in policies and plans for continuity of essential health services and health system recovery. About 2/3 of countries have policies and plans for continuity of essential health service during the pandemic, and half of countries have plans in place for building longer-term health service resilience and preparedness. This is these both are actually key elements in ensuring the condition of the national health system remain intact. More than 2/3 of countries then support these policies with allocating additional funding for long-term health system recovery. So investing in health system resilience, health system recovery, for health system preparedness to ensure that we are better prepared for the next pandemic remains a priority for countries. However, there are bottlenecks to scaling up access to COVID-19 tools because we are still currently recovering from the pandemic. There is lack of funding, health workforce challenges, supply and equipment shortages, lack of distribution capacity, lack of clear strategy, guidance and protocols, and lack of data and information. These 6 elements remain the key bottlenecks to ensure that we are better prepared, to ensure the health system are prepared for the next pandemic. Countries reported priority needs for maintaining continuity of essential health services, and they are doing recovery as well to be able to mitigate these bottlenecks. But then the question lies upon where in the health system that priority needs to rest. And WHO recommend that primary healthcare promotes equitable recovery from COVID-19. It can accelerate progress toward the 3 billion and also the SDGs. So investing in primary healthcare actually enable country not only to recover, but also to recover to get back on track to achieving the 3 billion target, and also to get back on track, catching up on the SDG targets that were left behind because of the pandemic. PHC is the most equitable and effective strategy to enhance population health because it is supported by the 3 pillars: the healthier population pillars, universal health coverage pillar, and health emergencies. These 3 pillars are the foundations to achieve health and well-being. The operational framework of PHC levers to strengthen PHC, and it has to prioritize on these 3 key elements: SDG 3, health for all, and universal coverage. By adopting and adapting and implementing the PHC operational frameworks, then the results to improve access, utilization, and quality can be achieved. Improve participation, health literacy, and care can be achieved, as well as improved determinants of health. I will close there, and thank you for the time. Thank you.
Thank you very much, Ms. Dia Saminasis. I think you already covered about the issue, but without further ado, I'd like to invite any comment or question from the participant. Or is there any from the chat? Let's see. Okay, please raise hand if you want to ask the question or give some comment to the presentation of Ms. Dia Saminasis. None. Rama, any question from the audience? Do you see some people?
Yes, I think we're still gathering the questions, sir. We're still checking on the question. Okay.
Yeah, but by the time I get the 6 point from the presentation of Ms. Dia. One is COVID-19 become disruptive for our process to achieve good health as the main outcome of the health system. 1992 countries reporting their decision in 3 rounds of post certified by WHO. Second one, all level of services have been started, community, primary, referral system, including emergency services as well. And almost half of countries having a backlog on essential health services. The number 4 is countries were trying to mitigate situation by increasing surge capacity of its national health system by allocating more funding and human resources. But of course, if facing the 6 bottlenecks, including funding, resources, medical devices, data and system, policy and procedure. And therefore, WHO recommend improving primary healthcare as the basis to facing threat of the future or next pandemic. So that I think 6 points I got from the presentation of Ms. Dia Saminasis. So we still invite some question, but the time is approaching to be finished in 1 minute. There's two questions, Ms. Dia, in the chat. Is there any significant differences in financial allocation to fund primary healthcare before and after the pandemic? And the second question is, what is the policy strategy that potentially will give the biggest boost to tackle the disruption in primary care delivery? Please, Ms. Dia.
Thank you for the questions. For question one, the significant difference in financial allocation to fund PHC before and after the pandemic is, I think, during the early phase of the pandemic, funding for PHC was allocated primarily for the acute phase of the pandemic, which is to provide more response type of budget needs. For example, PPEs, extra medications, extra tools for health devices to make sure that the service in the primary healthcare can continue. However, after the pandemic, the priority or the policy priority or policy direction needs to shift a bit from acute phase or response phase to preparedness phase, where the budget should be allocated more in the investment of health workers as well as community health workers. It should be allocated in the data and digital health utilization to ensure access and quality can be achieved at the same time in the service delivery in primary healthcare. I think that's the broader sense of things. WHO also recommends that 1% of GDP can be allocated to primary healthcare. But however, that being said, it also can mean that the 1% of the GDP must also correspond to priority areas and actions that the community needs the most. And perhaps that is also, again, investment in community health workers, in health workforce, and also in the data and availability of data and utilization of digital technology in primary healthcare data. I will move to question number 2, the policy strategy that potentially will give biggest boost to tackle the disruption in primary care delivery. I think prioritizing in primary healthcare is key in our effort to rebuild and ensure that the health system remains intact and stronger. Not only intact, but it will be in the future. Health system is more robust, more resilient, and more stronger than the condition it was in during or before the pandemic. WHO again recommends that primary healthcare be is the cornerstone to achieve UHC, and it's the most affordable options for countries to get out of the pandemic. So prioritizing the primary healthcare is the policy strategy to tackle the disruption. There are three more questions.
Just one question about the worker. Can we add more people or more workers because there's the problem shortage of the worker in the primary healthcare?
Yes, I think when we talk about primary healthcare, we must also set our minds to think that primary healthcare is not only in government-owned or public space, it's also public and private space of the healthcare delivery, and an integration of public and private services in primary healthcare is needed. So in the context of your question about health workforce, it is also essential and key to reach out and to train and to invest in the health workforce in the public sector and also in the private sector of the primary healthcare, in the primary healthcare. the type of investments can vary. Of course, it can be education, it can be more training, whatever the countries need or identify as key elements to be able to boost the performance and capacity of the health workforce, and that also includes capacity of the community health workers. There are two more questions. Shall I move and answer?
Please,
Okay.
about the health insurance and also the specialist kedokteran keluarga. And,
is it possible?
Yeah. Yes, this is last question, please. This is last question.
Last question, okay. There are three more, so I will just pick one.
Yes, please.
Okay. Primary health face hard time during pandemic, and okay. So question number 3. The question is it possible if strengthening PHC by giving or adding more worker there? Will it be possible and effective? Of course, during the acute phase of the pandemic, we need more health workers there. But also bear in mind that there is also the community health workers that can be the proxy or the support system of the health workers in the primary healthcare. Adding more community health workers and or health workforce during the acute phase of the pandemic was not only necessary, but it is required. At that time, there was no option but to add more. But now as we progress from the acute phase to the chronic phase and towards the preparedness phase of the health system, adding more people should be coupled with more training, more capacity building, and more support mechanism to ensure that they can do their duties and tasks effectively and efficiently. I think this is where digital health comes in handy, digital support, so data availability digitally, ensuring that there are interoperability between data system and database will make sure that people, health workforce within the health system can carry out their tasks effectively and efficiently.
Okay, thank you very much, Ms. Dia Saminasi, for the answering the question, and thank you very much also for the audience who provide question, very effective question and answer. But unfortunately, our time is run out now. So what I would like to conclude is, of course, COVID has effect to our health system and disrupt our system, including all sector of the health system, from the primary, secondary, and also tertiary. So what we have to do is invest in terms of health system, but the basic is the foundation is the primary healthcare as the foundation of the building of the health system. So investing means more people invest and also more funding allocated in order to achieve and the readiness of new public health system, as well as to facing the next pandemic or another threat from the pandemic in the future. Thank you very much again, and over back to Rama. Thank you very much.
Thank you so much, Mr. Ede and Ms. Dia. I think we all agree that that was a very good opener for today's webinar. So thank you so much. And we have seen that we have a lot of questions coming. So please, all participants, if you feel like you want to ask something to the panelists, we still have 2 more sessions. So please prepare your question and send it to the Q&A feature. And so we are going to continue the event with an interactive panel discussion session under the title of Key Lessons Around Public Financing of Healthcare During the Pandemic and Beyond Towards Creating a Resilient Health System. We are delighted to have our 4 speakers coming tonight as the panelists, and to guide the session is our moderator, who is a health financing expert with 25 years of experience in low and middle income countries, including Mozambique, Angola, Congo, Haiti, Nepal, and India. And he has worked with several multilateral and bilateral aid agencies, including UNDP, UNICEF, the European Union, WHO, and USAID, among others. His working exposure to all health systems level, from facility to ministry, has given him a wide understanding of how to analyze performance to all these levels. He has worked also on social health insurance institutions, supporting many areas such as enrollment, benefit package development, provider payment mechanism design, and overall governance. And tonight, he is already with us, is the Regional Advisor on Health Financing and Service Delivery for WPRO, World Health Organization. Please welcome Mr. Luis Final Torres.
Thank you very much, Rama, and thank you for the very nice introduction. Welcome, everyone. Good morning, good evening, and good afternoon, and thank you for giving the opportunity to moderate and to enjoy and to learn from all of you today. I think it's a very exciting program that has been put together here, and I think and I hope that the 119 participants that have joined have the same feeling. This second session, it's aiming at looking at the key lessons and on the public finance for healthcare for the pandemic and beyond. And this session is trying to look at how countries have been using their domestic public funding mostly for the response to the COVID. And it's important a bit to frame the discussion. There is countries that have been using social health insurance schemes. So through reimbursements, they have been trying to fund treatment, the access to vaccination, and basically using the schemes that were in place to fund the response. Other countries have been using their budgetary systems, and then they have been basically tapping on their procurement procedures, but also in this budgetary of all sorts of forms to fund their activities. And for this second group, it was WHO. We have been studying how the countries have been basically balancing between the flexibility and control, because the response required levels of flexibility and urgency that we've never seen before at this scale. But at the same time, you want to keep your public finance management system to keep control and to ensure that the money is spent correctly. So finding this right balance between flexibility and control has been where countries have been struggling in many of the regions. And what we from WHO, we have been trying to learn how these countries have dealt with this challenge and see how the lessons learned from their response can be brought to the future. No? If countries have been finding successful arrangements and schemes to using either budgetary schemes or reimbursements from social health insurance that have been able to successfully answer the COVID-19 challenge, how these new innovative arrangements can be used for the future. This is just introduction. It's a bit to frame the discussion. We have two great panelists, and then after their inputs, we hopefully will have some time for answering questions, and I hope that it will be very rich. The first panelist, it is Prastuti Sewendo. She's the special staff of the Ministry in the Ministry of Health of Indonesia for the Republic of Indonesia. She's also a lecturer at the Public Health Faculty at the University of Indonesia, and is actually a very renowned global expert on health financing and on social health insurance, having helped all many countries in the region, especially in Asia, but also globally in health financing reforms. The first presentation with Prastuti or Ibu Becky, how more of friends know. The first intervention will be more about how Indonesia, which has used the demand side of the solution, we were talking supply and demand side of solution, how it has been used, what has been the challenges in these solutions, and what can be learned from the COVID-19 response for the future. I stop here and give the floor to Ibu Becky to guide us and to see what can we learn from the Indonesian case. Over to you. Thank you very much for being with us, Ibu Becky.
Yeah, thank you so much, Luis, and very glad to meet you, and thank you for a very generous introduction. And I would share our experience from Indonesia on this response to COVID. May I share my my slides? Okay, where is the slides? Okay. Wait, I think I need helps. Okay, I think this one. Yeah. You see our slide, my slides? Okay, thank you. This is the health policy response. I'll start with the health policy response that the Central Financial Policy and Stability in response to COVID, we have a law. We develop a law and a technical regulation of law. Also, especially we have a program for budget policy relaxation, increase health budget, stimulus to protect vulnerable population, and also aid business to support the economic recovery. So in the 2020, we have an allocation about 48.3 million, and 13% is for the health sectors, but in the 2021 the budget is increased slightly, but the proportion for health is increased substantially. So in the government of Indonesia allocate a huge amount of central budget for COVID response, especially for health sectors, and we pulling the funds by doing refocusing, reallocation, and we have a contingencies funds from the Ministry of Finance allocated to this. So in the 2020. There is a program for, as you can see in the list, handling expenditure for COVID, and then we also pay the incentive for the health workers and also compensation. And we know that many people, industries also suffer from this emergency. So there is a premium contribution subsidies, and then there is a task force and vaccination, started on 2021. So this money in the pooling is will be allocated to not will be, but it's channeled to the ministries and line ministers and also subnational. You may aware that Indonesia is very strong in the fiscal decentralization. So we start to also compare what is in the 2020 and the 2021 using the public financial management framework. And as you can see in here in 2020, since the COVID was hit in Indonesia starting on March, so we have to do kind of revise the budget. So basically in the budget formulation is a top-down budget policy, and then the special budget process, not following the standard guidelines in terms of budget flow, timelines, and formula, but there is a budget reductions also through consultations with the legislative. The local legislative was also involved. And then Ministry of Finance and Ministry of Health set up a kind of special regulations to be able for the local government and also central line minister to flexible use them, reallocate their money. And we have a special allocation for special allocation funds, and so we set up a menu adjustment, desk review, and final identification, and that's all done in the budget formulation. For the budget executions, the disbursement mechanism is actually following the existing mechanism, but unfortunately we only can get up until 63% of realization, because many of the local government who is fully decentralized do not want to, it's not kind of a flexible, or they don't understand how to react with a top-down budget policy and etc. So for the incentive to health workers, we found out that the formula was kind of too rigid and it's unfair, and many complaints, and there is a delay in payments for the health workers. And issue in the subnational, in the quick response, local government also use their contingency funds at the local government. And then the other key source of fundings, we also fund finds very high support from the private, philanthropists, and then also communities. At the monitoring in the 2020, the Bureau of Planning only received spending reports from the applications, but not no field supervisions, and many feedbacks and findings, of course, but because of the emergency situation, it is possible to lean the audit standard. How about the 2021? In the 2021, actually learning from the previous years, so the budget formulation process is more structured. Yeah, so this is the new Minister of Health was appointed, I think, in the December 2020. So he defined 4 pillars for this, for the COVID, yeah, 4 pillars. The first one is testing and tracing budget, and the second one is for therapeutics, quarantine, including quarantine and hospital, and then vaccination, of course, and health worker incentive. So in addition to the central budget allocation, we also asked the subnational to allocate their budget COVID using their local budget, and then the guidelines. The central budget are strictly mandatory, or giving instructions to the subnational that execute the vaccination, except for the vaccine. The vaccine will be it was procured by the central. But there is a special instruction that the budget for executing the vaccination should come from the local government, with the additional support from the private companies if there is any. And then procurement vaccination from the Ministry of Health, but the execution will come from the subnational. So the Ministry of Health, the Ministry of Finance has earmarked some of the budget transfer to the local government to support the vaccination. And then for testing and tracing, yeah, for tracing and testing is done by the local health clinics, we call it puskesmas, using the budget transfer. So and then the issue in the budget execution is technical guidelines. It came late, yeah, but in terms of budget structures, it's more firm in the 2021. So I also want to share with you the budget execution issues in the incentive, paying the incentive to the health workers. As you can see that there are several regulation changes. Yeah, there are several regulation changes. The first one is too rigid, and then they modified it and continue to modify it. They changed the technical guidelines for distributing incentive, creating confusion and perception, and then the verification was centralized at that time, so it takes too much chaos. Yeah, a lot of incentives were delayed, and due to high workload in the verification process by the Ministry of Health at the central. Incentives were transferred through the health institution. It may also delay to transfer to the staff. So this is a lesson learned from we want transparent, we want accountable, but it creates too much hassle. And with the vaccination, all vaccination, as I mentioned earlier, is provided by the Ministry of Health and distributed to health providers and other institutions which provide vaccination center. Many of the private industries and individuals also support the vaccination. They develop their own vaccination center, and the vaccination and the health workers come from the government. So the operational cost for vaccination provided by institutions, mostly is from the institutions, but there are also additional private industries. So the challenge is many workers were multitasking at this time because they become also not only doing the vaccination, but also as tracers, yeah, testing and traces, but couldn't claim the incentive due to the regulation limitation because you only can claim one, but they are doing multitasking. So this is also another issues. And then for the testing and tracing, many workers were also doing testing and tracing, and they have to also guide the patients to the hospitals. It's kind of but they couldn't claim the incentive because of the regulation limitation. So the number of tracers, mostly from volunteers recruited, also very limited, and many of them was also exposed by the disease. And how about for the hospital claim reimbursement? Because most of the budget is also for paying hospitals who treat the patients. And as you know that we changed the payment systems. As you know that the social health insurance now, the assisting payment system using CBGs, the package, but for COVID, we changed the payment systems to per diem. So many of the hospital has to comply with the regulation. They have to submit the claims with daily support of documents. So this is also become a burden for the hospital. And as you can see in here, the regulation is also continuous change. Yeah, the administrative procedures, the clinical guidelines is also changed, and the challenge is complexity of the administration and document requirements, understanding the gap of insurance criteria, and period of limit of treatment coverage is also become an issue in here. This is just give you a glance on how complex, that the clinical setting. We use BPJS, the agencies for the social health insurance, to do a verification, but the requirements of document, as you can see from A to G, there are many and weeks to months to submit the claims, and hours and days to scanning, because everything should be uploading in the electronic e-claims, and then after that the social health insurance have to review it based on the fee claim, and then it creates delay. This is just give you a glance that the regulation is changed, but to get the claims, the hospital claims, it has a long algorithm that they have to go through that. So from that, we also learned that with the changing in the regulations, the dispute claims become increased. As you can see before and after, this is just on the top graph is just comparing the before the decree 238 is the previous decree, and then they changed the decree at I think around August, and then the dispute is also changed by 33%. So there was a rise in numbers of dispute claims after the decree was implemented, but the surge in cases claims in hospital during the period of August 2020 and March 2021. It's because the hospital worked in collecting supporting documents. And this is just give you a glance, that the budget planning and executions, that there was an improved budget execution capacity in 2021. As you can see that the total budget is 90 trillion in 2021 and become triple in 2021, but the realization is also increased from 63% to 92%. More detailed budget menu for 2021, as you can see, the budget menu is expanded, and then higher amount of budget in 2021 was affected by increased case of COVID and more prioritization by government for strengthening the COVID response and fiscal support for subnational that has limited fiscal capacity. So what's learned? What we learned from the COVID? So we are lucky that the health budget realization has increased substantially in terms of the total health expenditures. Actually, the proportion of public versus the private, the non-public, is also balanced. Previously the non-private, the non-public is dominated, but now with the COVID in 2020 and 2021, the public financing to total health expenditures around 51%, 52%. So this is quite a good news to increase the budget, the balance. And then the development from 2020 to 21 indicates that we need really a regulatory improvement, continues to modify the regulations, and periodic socializations is absolutely absolutely impact on the effective budget execution. So this is indicate with the improved absorption in the 2021, even the budget is larger. So Another lesson learned is you really have to have a close technical guidelines. The regulation should come up with the technical guidelines for the implementation, so they are not confused, especially at the grassroots, at the implementers. So this is very critical. And then the last one is the public financial capacity need to be strengthened in all the budget planning, the budget execution, as well as the budget monitoring and evaluation. I think that is my presentation. Thank you so much. And just note that all the results are come from the studies supported by Think Well Institute. Thank you so much.
Thank you very much, Ibu Becky. It has been a fantastic presentation, and I think you have covered the both sides of the response of the government of Indonesia. I think that the lessons that the Indonesia response on how the need for how to improve adherence to the rules in order to better utilize the money, that's the main area that we have to improve our collective learning, no? And in a decentralized context, which makes the number of the stakeholders very large, how we can ensure that these PFM pipes of money are working properly. And the second part, the funding through the social health insurance scheme, changing in provider payment mechanisms, the issues with the claim processing and the disputes, super important again for the same, how to manage this transaction, transaction cost, transaction challenge, the change of the rules, how we can manage more smoothly, I think it's two fascinating points that you have made of this very rich presentation, which I think that everybody has appreciated. Again, thank you very much, Ibu Becky, for your input. And let's hold for now the questions for the presentation. And I would like to offer now is a zoom out to bring the global learnings. We have just heard from Ibu Becky, the Indonesian learnings, fantastic. But now let's have the global learnings and see what the global health architecture has learned from COVID response. For that, we have Rushil Agarwal. Sorry if I pronounce properly. He's an economist at the IMF. He has been heading the Global Health and Pandemic Response Task Force, and he's going to share with us a bit what was the response, what we learned, but also what will be the implications of this learning for the future. So back to you, Rushir, and very nice having you. Over to you. Thank you.
Yeah, thank you. Can you all hear me? Yes. Excellent. So thank you, Pak Luis. Thank you, Ibu Becky, and salamat pagi to those I'm in the US, and salamat malam to those who are there in Indonesia. What I wanted to do, exactly as Pak Luis has said, the conversation in the previous session, this session, and the next session is a lot on health systems, strengthening health systems, and the challenges, financing challenges in the country. I wanted to bring let's say, a global perspective and why that matters, and bring it tied to the topic of the session, which is global health security. So why all the hard work that Ibu Becky talked about and her team has been doing, why does it matter for the global health security? So from that perspective, I will be speaking a bit more, let's say, speculatively, and things that may not be yet, or may not be IMF institutional view, but since it's a T20 session, my goal is to also stimulate discussion and debate, and to stay true to the idea of T20 to be the intellectual backbone of the G20. So that's that. Let me also at the onset congratulate, because I see a lot of colleagues from the Indonesian government side, your response to the pandemic and exactly getting it to a good, strong response at the subnational level from Aceh to Irian Jaya and getting the tools and in a timely way to all the families. That's a big respect and congratulations, because there are so many heroes who basically made that happen. So thank you for that. So let me begin. What I wanted to basically do is, if you see in the next slide, by the way, I also represent the IMF on the G20 Finance and Health Task Force. So at the end, I'll talk to you all a little bit about how this conversation fits into that conversation. What essentially in the next 15 minutes or so, I want to talk about three topics, which you'll see on the next slide. Is where are we today? What have we learned from the global perspective on the finance health side, and what is the potential path forward? So let's start by where are we today. One of the, I'm an economist. IMF is a institution that focuses traditionally and on core macroeconomic issues. And why are we even thinking about global health issues, at least for a small period of time? And so that's what the next slide will show. Basically, is one of the key messages from our side has been that pandemic policy is economic policy. So if the slide moves forward, there you'll see two charts in front of you. One thing that has been very widely and reported is the number of deaths. Officially, it's over 6 million already, about 6.4 million, but unofficial estimates suggest it was much bigger. But also on the economic side, the pandemic has had a huge cost. So before the war in Ukraine, we had estimated that the cumulative losses from the pandemic through 2024 was about $13.8 trillion. So that's, the global economy is about less than $100 trillion. So that amounts to about 15% of a single year's GDP, but over 4 years. So that the cost has been big. That translates into jobs and livelihoods. And so part of our message was and has been is ending the pandemic as fast as possible is not only good for global health, but also is good for global economic security and global growth. So that's kind of where we are from where we are coming from the economic angle. As we go to the next slide, what you will see is the basically three messages that I wanted to leave you all with on this. Where are we today? Pandemic is still not over. Maybe the acute phase is behind us in many parts, but different countries are at different phases. Even within countries, you have different experiences, and the health and economic costs continue to grow. And there is still some unequal access to the core tools, vaccines, tests, and treatments. A lot of focus now is also on the treatment side. Second, the virus is very likely to stay with us for the long run and may circulate indefinitely. And we need a strategy to move from an acute response type phase to transition into dealing with comprehensively how to deal with the COVID in the long run, while going back to all the other social and health priorities that we've put on hold for over 2.5 years now. So that's kind of the other. And so we have a new paper that we wrote with Geeta Gopinath, Peter Sands, Jeremy Farrar, and Richard Hatchett, that kind of laid out that new strategy from our perspective. And then the last thing is still there are large uncertainties on how the path of the virus will unfold. There could be very different scenarios, from a mild endemic scenario to a more dangerous variant scenario. And so the financing and the global strategy needs to take into account those uncertainties and not just base on the baseline and just hope for the best. So that's kind of another big thinking, and let's say the financing framework from the global perspective are moving a bit more in this direction. So let me move to the next slide then. And I've already previewed some of these key implications that comes from this paper that I mentioned. Is important that now we can ensure there's equitable access to the comprehensive toolkit, because it's not clear that each single line of defense may be as effective because of waning immunity of vaccines, for example. So we've emphasized the need for a comprehensive toolkit of vaccines, tests, and treatments, so that there's less fear that that basically going to work, going to school is going to put you up in the hospital. Just having access to all those tools is going to help secure that. Second is the virus is very plastic and evolving very fast, as WHO colleagues here know very well and have studied, and other health colleagues. And so it's very important to monitor through genomic surveillance, testing, monitor the evolving virus, and dynamically upgrade this toolkit that I mentioned in point one. A third, as I mentioned, is important to also for national governments and the global multilateral system to think about how can we transition. In a way, we've been forced to transition already because of various global developments and problems with food and energy prices now. But having a more concerted thinking about how can we transition to that sustained balanced response to balance other priorities will be important. And also, Ibu Becky already talked about those challenges from a country level earlier. And then last, and I think I bolded this because I want to put on the table for discussion is to shift the thinking on global health issues from just a development issue, which it very much is, to also a systemic risk issue. So in a way, what we've emphasized in our work is the need for a unified approach to fight pandemics. And given that budgeting and financing is going to be harder and harder to find, potentially, given other developments, to find complementarities and have better coordination to enable a better and faster response to such threats. So let's move to so that's kind of where the first thing on where we are today and the current thinking, at least from my perspective. Now, some few lessons that the next slide we'll see is, so these are just references that you'll see later, where you can refer to these papers that I mentioned, where we laid out some of these ideas. Let's go to the next slide, is basically moving on to the next section, the part two of what I want to talk about. What have we learned? And we just dive directly in there. In a way, if you see the next slide, is the way, if you think about from a pandemic perspective or an epidemic perspective, in a way, the global challenge once the pandemic begins is basically threefold. You innovate and develop new life-saving tools to fight that pathogen. Second is produce this in large quantities. And third is to make sure it's equitable, is available in an equitable way to all citizens. And given the global public goods nature of this, of fighting these pandemics, it's important to have a multilateral coordinated solution and financing for these solutions. So it's not enough, and this is where I want to bring the security point, which is, it's not enough if one country has invested in strengthening the health systems, but our 95 countries have done it, but the 96th country has not. And because the vulnerability there could basically spill over to the other countries. So it's important to have a global perspective and take a security perspective there. And that sometimes may require financing because they're low-income countries with strong, severe budget constraints that they may not be able to allocate the necessary funding to prepare or prevent pandemics. And what we learned during the pandemic is we faced obstacles in each of these three steps, especially in step 2 and 3. Let's turn to the next slide. We have a paper with Geeta Gopinath, our first deputy managing director, where we lay out the 7 lessons. I'm going to just talk about 3 lessons here for our present discussion. As I've already been previewing, the rationale and source of financing is we want to encourage the global community to think about pandemics as a systemic risk issue and not solely a development issue. So in a way, what that means from a financing framework perspective, from a global financing framework perspective, is to put more money on the table. The first line of defense should be grants to facilitate and support countries where they don't have enough domestic resources. The second line of defense can be concessional financing from multilateral development banks. And then the third line of financing is exactly what Ibu Becky talked about, is domestic financing, where you have to fight challenge of investing in health versus other priorities. So that's how we think about it. And the more we can make the economic case for why, the more we can help, have a more integrated global budget for health priorities. I just basically summarized that, so we don't have to read the rest of the slide. But maybe one thing I'll just say here is, in this respect, the funding allocated from a global perspective to fight pandemics or strengthening health systems, there's a strong economic rationale for why that should go beyond what's called the ordinary, ODA, the official development assistance, and that because it's not just good for it's not just for the goodness of the heart that the high-income countries would put this money on the table, but it's also good for their own security and global security. So that's the logic we want to push there. Let's move to the next slide, lesson 2. The current work in the multilateral system, a lot of work, including in the G20 task force, has focused on the preparedness side of financing for the preparedness for pandemics, including for strengthening health systems. But one of the things we did learn in the pandemic is what I call day zero financing, the need for financing available and what is within your flexible financing team. In a way, financing available on day zero to quickly respond to the needs. So a thought experiment for that helps crystallize this point is, if you look at COVAX on the vaccine side, COVAX had procured about $10 billion. They received $10 billion in grants by June or middle of 2021 to buy vaccines on behalf of developing countries. And that was enough to get 30% coverage or more in developing countries. But if they had gotten that same amount of money just 1 year earlier, the global response would have been very different, and the equitable access to tools, to vaccines in this example, would have been very different. So the more we can make sure that kind of rapid surge financing is available at the global level, but potentially also, listening to Ibu Becky talk about her challenges and how they've how they responded to COVID. Also, there's potential to think about what this means at the country level, right? In a way, Indonesia itself is a continent, and getting the funding all through to all corners of the country has these parallels to the global response. So let's move to the next lesson 3. That's the only one more I have in this section. So there is also a lot of, so there's some other work that I have done with my colleague Patrick Golay on R&D. There is now, as many of you know, in the international fora, discussions about risk of fragmentation and risk of difficulty in achieving cooperation for global public good outcomes. Yet, what the pandemic did show was our species, humans, can come together and do incredible things in creating new things, so in innovation. And so this is a work we did where we looked at how fast was the R&D response to COVID. And our work on the chart here you see is the number of new trials started in the world. Roughly 300 trials are started every month, clinical trials. And in the first few months of COVID, basically that number nearly doubled, and just less than doubled. So and we saw that translate into products like vaccines and treatments at record speed, and a lot of those products happened with cross-national cooperation. So one of the optimistic messages, at least I want to share with you all, is can we apply that human ingenuity to solve other global health challenges and beyond global health challenges, big challenges facing humanity? And I think those are the lessons we should try to come up with. What are the financing framework and incentive structure that can help us translate that to other problems? That's the work, basically what this work that I've been doing tries to start exploring. So let's move to the next. And in the next, you'll see basically some of these resources which you will get when you get the slides. The last one may seem a bit unusual, that's about chimpanzee politics and climate change. That's where I asked the question: where can we come together? Are we evolved enough as humans to truly rise above domestic issues and work together to solve the global problems, and what we can learn from the animal kingdom? So that's kind of, I wanted to put that in as a message of inspiration there. So let's move to the next. So in the remaining few minutes, I will just talk about the last section. So I've been a bit high level. Let me just try to be a bit less high level now in the remaining few minutes. What's the path forward? So if you see the next slide, in a way, one of the incredible things, and my congratulations to the Indonesian presidency for pushing the finance health agenda, is just that we are meeting together with the finance ministries and the health ministries. That conversation in several countries was happening maybe more organically, but now there's a collaboration, a formal interaction within the country and across countries. And that's really, I think, quite special. So it opens up new ideas, new ways, and ways to bring the attention that sometimes the finance ministries have in terms of financing power to the problems on the ground that the health ministries often face. So the focus of, we've had 4 meetings, and of course, as you know, last month there was the ministerial in Indonesia. The focus really has been on PPR. Sometimes the word prevention gets dropped. When people say PPR, they say pandemic preparedness and response. And one of the questions that we got in the previous session is, what are the highest returns for investment? Actually, sometimes the highest returns for investment could be very much prevention. So anyway, the key discussions in this joint task force has been around rethinking the global health architecture and the financing, finding a way to create financing and health coordination, and also thinking about creating this financial intermediary fund at the World Bank. So let's go to the next slide. I just have one more, I believe, or 2 more slides, basically, the second last. And the idea I want to emphasize, leave you with, or even kind of set the stage for an exploratory questions, is important to think about the global health issues as more of a global public good problem. And a broader lesson from the pandemic is that we need better stewardship of the global commons, including global health. And in a way, I think it would not be a stretch to say the lack of a effective global architecture has prevented us from having an effective and rapid response during the pandemic. And now a lot more discussion and thinking and creativity is needed, at least around these 4 things I've listed at the bottom of the slide. How can multilateral institutions deliver on the mandate and work collaboratively with each other? So that's what we try to do at the Multilateral Leaders Task Force, which brings together the IMF, WHO, World Bank, and WTO. That was building on the insights of the IMF pandemic plan. Second is, how can we get people at the table to take ownership and feel ownership of the global public goods, including the global health security? Third thing I've talked about, which I just want to put a bit more attention, so I put it there as a third bullet, is, can we think more creatively about these having rapid and adequate financing windows for global public goods? And fourth, which I've not talked about but is a big topic, and I just wanted to make sure that we at least mention it, is how can we diversify supply chains with regional manufacturing, including for vaccines? Last slide, and that's the next one, is just based on everything I've said, if you've fallen asleep, maybe you can wake up and kind of think about this, questions that I just want you to leave you with, and maybe have go back to in the discussion. I was thinking to organize this into 3. One is finance. How can we reimagine the global financing architecture and the coordination arrangements to address systemic health threats, but bring in the country perspective so there's a complementarity with what's happening at the global level and the country level, like basically the interaction between the two talks of this panel. Second, on trade and supply chains, there is one can say, a fear of trade barriers, fear of nationalism, vaccine nationalism, as we saw during the pandemic. It's important for us to collectively work on this to make sure that we can enhance, strengthen the rules of game and have, reduce the systemic supply chain risks to support the global health agenda. And the third is this thing on the R&D that I mentioned. I want to leave you all with that, is how can we scale up financing of ideas and global innovation, as we did during the pandemic, to fight health challenges and other major challenges in the world. So let me stop there. Thank you for your attention.
Thank you very much, Ruchir, for fantastic presentation. And as you have put it, you are bringing the macro picture, stressing the link that keeping a healthy world, it's a need for economic development. An important link, and it fits very well the macro picture that you are bringing, and ensure that resources will be mobilized when we will need again. But then with Ibu Becky's point, let's say more the micro picture and the challenges of implementation at country level. Great, thank you very much, Ruchir. Colleagues, we have 9 minutes left, and there is a lot of very important questions in the chat box. While I'll give Ruchir some time to look at questions related to him, I would like to give the floor to Ibu Becky, 5 minutes, if we can allocate five each of you to address the ones that you think more of us will benefit from your answers. Over to you, Ibu Becky. Thanks.
Thank you. Thank you for all the questions. I'll try to respond. The first question is about the public versus private. So whether is it okay, to have more public spending, proportion of public spending rather than non-public spending. So as we can see that in the health spending from the national health account, the spending increased quite substantially. We spend about 122 per year per capita, but our spending as compared to the total health expenditures is quite low, and it's consistently low. It's about 3.2% of the GDP, and we still have struggling to increase the total health spending. And then social health insurance is getting improved, and also the proportion of social health insurance is also increased. So that helps also because it's counted as the part of the public spending. But in growing health spending, it's not really capture, or it's not really produce good health indicators. So we the multi-mortality, infant mortality, TB, non-communicable disease are still struggling with us. So I think obesity is also a problem, and I think COVID opened the opportunity for the people in health to get attraction, to get okay, I give you a challenge now, how you can improve, and then also improve the health systems, and also improve the get a value of money. They realize that health can impact on this track on the economy. So I think this is a very good time after the COVID. It's very easy, but you really have to have a programs, the good programs on that one. So I think I don't have any doubtful that investing in health, and even public dominated by public, it's good, as long as not, now we are in an okay position, balancing about 51% to 49%. I think that is quite a good proportions. The second, that's why in terms of value of money, I think we have to, in the transformation, we have to invest more on the prevention, promotion, and as well as investing on the primary care. So there is another questions about Satu Sehat. There is, I think the minister just launched yesterday about the integrated data for health systems, that being able for us to get the disease pattern. So I was involved in the question is whether it's more resilient, whether it's really contribute to the health system, strengthening the health system. So I think I was involved in the production of a national health account for 10 years. I met Luis during one of the meetings on the national health accounts. So Minister of Health now has produced T-1, and the minister used the national health accounts for future budget planning, and this is I think a good opportunity when I present, and he acknowledged that why we spend mostly to the hospital, and what kind of disease, and mostly the chronic disease, and where the patients get to the hospital at the very severe conditions. We cannot do anything. So what we need to invest with this money? What should we invest? So what he's doing is now shifting all the investing in hospital to the primary care, and this is start this year. It's already start 2022, but mostly, I mean, the reallocation will be more proportional in the 2023. So I think this is primary care. Of course, it's quite a challenge to really invest in the primary care, but we do the screening, we expand the immunization, we do the screening, and with the backup of the data, we are trying to capture and follow up. Once you are in the high risk, and then with the IT systems, we will follow up the patients to ensure that they get treated and reduce the risk factors. And then I can speak with that part on and on. One more is, I think, with a question whether it's very easy, 200 trillion spent for COVID, and why don't you just shift it to the social health insurance? I think this is quite a challenge, and I think we are refining the tariff now, so attraction and contribution will be also the only thing is on the 2024 we have a political year, so kind of difficult, when we make some adjustment or contribution or something that really it's a political year, so we have to be careful on that. But I think we will go into that end. Thank you so much.
Thank you very much, Ibu Becky. And I'm so sorry to rush you, because you are touching very good points. And actually, the use of the COVID response learnings, but also the opportunities for example, shifting towards more preventive care, or to put attention on primary health care funding, which is definitely a way to go to improve the efficiency of the system. It's a very welcome news. Rushir, please select the two most preferred questions.
I think I can handle, in 90 seconds, I can handle three. So
fantastic.
First question is about those donations. I think what we learned is very hard for countries to do the right thing, because it sometimes cannot be voter safe to do things that help the world. So part of our duty, since we are health economists here as well, is to make the case for why it's important and make it more voter safe to do things like those donations. So one of the ideas we came up with was swaps for places in your queue. So rich countries just give up their place in line to COVAX or African Union to allow them to have quicker deliveries, which some of them actually implemented. So we have to be creative and help make more voter safe policy ideas to do the right thing. Second, on the financial intermediary fund, it's good that people are around the table. That's a huge progress, and there's ownership. It'll be important to now, there's a lot of details still working out, but it's important to make sure that it complements existing financing and not substitutes. So that's kind of the priority now. One thing is we need investment in prevention, and we need to think about how to get that. Last question was on the what can we do to make things track these things. Again, I'll just say here, transparency and communication. It is also our duty as economists, at least as I see it, is to help clarify what the issues are and make it directly reach out to the citizens to get them engaged and tell the story in the clearest and most intellectually honest way, so that we can all do the right thing for the world and for our communities. Thank you.
Fantastic. And let me pick on this last point, Rashid, to promote transparency and sharing information as a public good. And I think that's a very great way to finish this session too. Thank you very much. Ibu Becky, Rashid has, I think this combination of macro challenges, lessons learned and next steps, and micro challenges and next steps and opportunities. Well, I learned a lot and I have enjoyed the conversation, and I hope that everyone else has. So again, terima kasih, and I'll give back the floor to Rama. Wish you a pleasant evening, morning, or afternoon.
Thank you so much. Terima kasih kembali, Mr. Louis. Thank you so much for moderating the session, and also thanks to the panelists. And now we have come to the last session of today's webinar. Ladies and gentlemen, but before we are moving forward, we would like to remind all participants to fill the attendance form and the evaluation form that has been sent in the chat box so that we can conduct our next event better. And now, ladies and gentlemen, let's continue the event with the last session of the day, which is a panel discussion session under the title of Zooming In on Building Resilient Primary Health Care. And to lead the session is a moderator who is a senior economist and policy advisor to governments in Asia, Eastern Europe, and Gulf cooperation countries in the Middle East. He has both research and operation experiences. Most recently, he is working as a health financing advisor for USAID and the government of Indonesia. And prior, he was with the Bill and Melinda Gates program in India and was a lead health economist for the World Bank in China and East Asian countries, including Malaysia, Indonesia, the Philippines, and coordinated health financing and health insurance thematic group within the World Bank. Joining us tonight is our moderator. Please welcome the Senior Health Economist of USAID, Mr. Jack Langenbrunner.
Thank you, Dr. Rizky, for your kind words. Good evening, good day, good morning. Salamat pagi, salamat siang, salamat sore, salamat malam, wherever you are. Welcome everyone to this next session of the day. These have been great sessions. Great discussions, but I hope we can provide some further great conversation and ideas as well in this next section. Our focus in this session is health financing and how it interacts with the centerpiece of any healthcare system, namely primary care. And secondly, how do we balance it? How do we balance it with our critical need for what I'm calling traditional public health? Traditional public health, not to be confused with public sector health funding, though often financing is public sector based. We will also drill down on tuberculosis care, and we know that TB care is both a primary care issue and a public health issue. TB care issues really move us from concept to reality on the ground. Let me start with a story, a real story, and that's a meeting in 2018 at the University of Indonesia. Professor Hasbullah and I and others were on the panel on primary care and public health. It was observed even then that one of the trends we were seeing, and this was pre-COVID, was that in many countries funding allocations for primary health care and public health programs were being squeezed. Perhaps not intentionally, but the numbers were starting to emerge, and the national health accounts in Indonesia and in other countries were quite helpful in that regard. Some of my WHO colleagues in Geneva in subsequent emails with them more or less agreed, though they said, well, we haven't really done any deep dive study at this point, so some of this is anecdotal, and that was well taken. The pandemic then closely followed. Certainly, the pandemic has taught us the importance of having a strengthened preparedness of health systems to tackle all forms of public health threats. And at the same time, we have learned that we must maintain a focus on the essential care coverage that is also affected by pandemic disruption. First and foremost, we must maintain essential health care. And what we often mean here is primary health care. Now, primary health care, or PHC for short, is often closely related with the integration of public health services. Again, what I would term traditional public health, such as surveillance, and related areas such as primary, promotive, and preventive health care. However, I think during the pandemic, we just heard from Dr. Dia that primary health care was not adequately included within the COVID-19 response plans in many countries, regardless of income, high, middle, low income, while at the same time, the routine health services were also disrupted, affecting important areas such as TB care. Recalling then, at the start of this session, what is the global notion in building the resilient health system, other than repositioning primary health care in the center and putting back its main functions? These are really the necessary steps to move forward. Tying things together as we start, sustainable and advanced health financing mechanisms play a critical role in building a more resilient primary healthcare system, and eventually accelerate the progress towards our collective goal of reaching universal healthcare in every country. Colleagues, forgive this somewhat long-winded introduction, and enough from me. To further address these challenges, I want to welcome our really wonderful panel, our stellar panel, Professor Kara Hansen, Dean, London School of Hygiene and Tropical Medicine, and our lead in the recent Lancet Commission work on primary health care. And I think that, if I'm not mistaken, Professor Hansen is also the current president of the International Health Economics Association. And she should know that Indonesia was the first country to have its own country IHEA organization. Second panelist, Dr. Yuli Faryanti. And our third, Dr. Faryanti is the current director of the so-called Pushcak PDK in Indonesia, or really the division that leads the health financing and decentralization policy and research for all of Indonesia. Our third panelist, Dr. Urban Weber, director of the High Impact Asia TB program at the Global Fund Geneva. And I'm giving short shrift to each of these panelists. Forgive me, but I hope that this will be shown on the screen so that we can move into questions. I want to welcome each of you, each of our panelists, and our session, our session will be a little bit different than the last one. It will be more of a roundtable discussion. At least a virtual roundtable of questions and answers, and we will hope our audience, as they listen to each of you answering my questions to you, will send in their own questions, and that we can address these later in the hour. So With that, let me start, Professor Kara, with you, if I may. And I wonder if you could set the scene for us with the Lancet Commission report on primary health care. What are the overall findings of the commission? How were they relevant to the pandemic? And I'm going to squeeze in maybe a second and related question here, which is how do we balance primary care with public health, and to what extent has the commission addressed this issue? I said one question, but now I'm giving you two. I thought that would probably give us a broader sort of setting to work from. So over to you, Professor Kara.
Thank you very much, Jack, and it's such a pleasure to be here. I'll just offer one correction. So I'm the president-elect of IHEA. So I will start my term in January 24. So after this, after the Cape Town Congress, which will take place in the summer of 2023. So I was incredibly privileged to be the chair of this Lancet Global Health Commission on financing primary health care. We started just as the pandemic was starting. So our first meeting of commissioners was scheduled to be in April 2020. It was supposed to have been a face-to-face meeting. And in fact, we spent our entire period of 18 months of deliberations working remotely. Despite the constraints of not being able to meet regularly, we spent our time kind of sifting through a lot of data and really reviewing the evidence on different elements of financing primary health care. If I were to sum up our message, it was the real message was that countries need to spend more, but they need to spend better on primary health care. So the spend more came from the observation that current levels of spending on PHC are very low. And when I say very low, in low-income countries, we estimated that countries are spending about $3 per capita per year on PHC, and in lower middle-income countries, that they are spending about $16 per capita per year. So we kind of shied away from coming up with our own price tag. Other people do price tag exercises, but the WHO price tag is about $50 per capita. If you think about the Commission for Macroeconomics and Health price tag for a comprehensive set of care that would include mostly primary health care, that would be $70 or $80 per capita. So countries are mostly very, very far away from that level of spending and really need to spend more on primary health care. But the spend better comes from just a simple plot of spending levels against coverage, and we just used as a proxy for PHC coverage. We used coverage using the UHC index. Again, most of which is delivered through primary healthcare platforms. And while it's definitely the case that those countries that spend more get more, there's a positive relationship between the level of spending and the level of coverage. There's a whole range of spending levels at which the variation in country achievement is enormous. So countries spending around $5 to $8 per capita find their UHC coverage index varying from about 20% to about 65%. So countries are doing really different things with that money, and they're spending the money very differently and achieving quite different levels of outcomes as a consequence. What we concluded through our analysis, because that was kind of the starting point, was that to address these joint needs of spending more and spending better, that countries can do a lot to improve their health financing arrangements. And this runs through all of the health financing functions. So one is that countries need to raise more money for health. And we felt that there should be a predominance of public funding for PHC. At the moment, a significant share of PHC expenditure is out of pocket, and that's an awful lot of spending on medicines. And there's a real need to increase public spending to help to drive out that large burden of medicines expenditure. Also, interestingly, many countries that are developing their kind of UHC schemes are not including PHC in the benefits package. And so we felt that the resources that are used to provide PHC need to be pooled. They need to be pooled, and schemes need to cover PHC first. We talked about how to allocate more for PHC, and that's not as simple as it seems. I think I entered the process being quite naive about what resource allocation means in practice, and I learned a lot. I'm happy to share a bit more about that. but also that countries have to think really hard about how they're paying providers. So there's I think we concluded that provider payment using capitation is absolutely critical for PHC, and that it's a bit of a journey to move from what are predominantly input-based budgets or fee-for-service to capitation payment, but there are significant steps that countries can take to move in that direction. Just a link back to the pandemic. The pandemic was really unfolding as we were doing our work. So we didn't look, at that point, there wasn't a great deal of evidence about what the impact of the pandemic was on PHC. There was lots of anecdotal evidence about some of the things that you talked about, Jack, about the fact that countries were not protecting their PHC services while they were responding to the pandemic. And that kind of had really a double impact. Partly it was people were reducing their use and uptake of key PHC interventions, but also those PHC platforms are important for that basic level of health protection, for management of chronic conditions. And if that is not in place, the people are ever more vulnerable to the pandemic as well. So it's really a double thing. And I guess well, let me just turn to your second question. So specifically around public health services. So we did think about this quite hard because the operational definition of PHC that's being used by the World Health Organization includes kind of primary care, that set of personal services that are delivered through PHC platforms. It also includes community-based health services. In many countries, there's a significant community-based workforce that provides services at the interface of the health system and the community. And the third is that it should include these essential public health functions, or sort of traditional public health as you were describing it. There's lots of evidence about the personal care bits and the financing arrangements that best support the personal care bits of PHC. There's quite a bit less on the financing of community health systems. We know a couple of things. We know, how community health workers are paid. And we also know that community health systems are predominantly donor funded across the world. But there's really very little evidence on the best ways to finance that public health package that's delivered through PHC platforms. And so there is a piece of work that's being done by colleagues at the World Bank to map out in some countries which of those essential public health functions, the health protection functions, the health promotion functions, and the intelligence functions, and those parts that are being delivered at the primary healthcare level, try to map out the arrangements by which they're financed. The early evidence suggests that it's enormously variable across countries, and that it's very patchy. And so in a sense, no one's got oversight for ensuring that those functions are appropriately financed and delivered. And I think that what we would take away as the main message at the present about financing the public health bits is that there's no clear model of how best to do that, but there is an orchestration function that's really important, a stewardship function that says these are these functions, and we need to make sure that somebody is responsible for them and that they are being financed, because they tend to be delivered under a whole range of different institutional arrangements. Sometimes that's through local government, sometimes it's through the health service, mostly it's through both, but it's through a real kind of somewhat haphazard architecture of both delivery systems and financing architecture. I'll stop there for now.
Thank you, Kara. That's great. You've really launched us into some areas that we need to come back to. More financing, better financing, defining public health, defining primary health care, the packages. So you've really opened up several lines of discussion for us that we need to come back to. So thank you very much. I want to move next to Director Ibu Yuli. Director Yuli Faryanti is the head of the Center for Health Financing and Decentralization Policy. She graduated with a master's in epidemiology from the Faculty of Public Health, University of Indonesia, and she has a general physician education at the Faculty of Medicine, University of Yarsi. So I thought health financing was a big job, but she has taken on both health financing and decentralization. And that's an even bigger job. I'm not sure why she would accept both of those areas, but I do think that it might make sense in a decentralized context to think about both of them together. So Ibu, my question to you is, you are leading on the ground for roughly 270 million people. And from your own experience and gained wisdom, how can we improve primary healthcare in Indonesia in terms of balancing acute care, public health, and financing? How do we balance these priorities? And can you then please move us a little bit into thinking about TB care? Now, TB care is a huge issue in Indonesia, we know that. Do we have some alternatives in Indonesia going forward? Over to you, Ibu.
Thank you, Jack. I think yes, I have a lot of homework for synergy financing until this decentralization. But if we talk about how can we improve primary healthcare in Indonesia, especially for the acute care, public health, and financing, we have something alternative for especially for the TB care. But I want to say it has been 3 years since we have been facing the COVID-19 pandemic. The pandemic has an impact of every sector: health, economy, tourism, education, and social, and has made us realize the vulnerability of our health system. And this pandemic raised our awareness and concern for the increasing investment in health, especially in disease control and prevention. Indonesia still has persistent health challenges, although there is improvement every year. Life expectancy at birth, maternal mortality, infant mortality rate, stunting prevalence. But in opposite, we still have stumbling blocks on other diseases, such as tuberculosis. We still at the second highest TB burden in the world based on the WHO Global TB Report 2020. NCD with mortality was higher than average number in South Asia, and the smoking with prevalence was the highest among ASEAN countries. It is why Indonesia has commented the health system transformation to promote a healthy and robust Indonesian population repairing, and we developed about the health system transformation. We have 6 pillars, and the first pillar is for the strengthening primary care transformation. If we talk about improving primary health care in some acute care, public health, and financing, especially of TB, for the TB program, through optimizing sources of funding other government, donor, or JKN through activity like one is about the preventive, for the strengthening preventive, is like BCG immunization, TPT optimization, and PPI tuberculosis. And the second video is about the early detection for the optimization contact tracing and of the ACF symptom, or like X-ray in specific, bidirectional COVID TB testing screening, and
one of the expansion and provision of access to screening, laboratory, diagnosis facility, and support, and like for the TCM machine and the others. And the third is treatment, like OAT, community involvement, and enabler support for ROTification, standard compliance and management for the involved the patient. And the fourth is collaboration for partnership. Is the we do about the like for the TB elimination acceleration at every level involved. And the second is we implementation for the district-based public-private. And the third is capacity building through the TB e-learning. And the other is digitization of the integrated tuberculosis information system. And the last is we do about behavior change or the increasing public awareness for early detection and the proper treatment, conducting massive TB campaign, and improving the media with the influencer and the TB survivor. I think we do it about the TB for the improve and develop to strengthen for the degrees TB. What else? TB for the decrease prevention to TB disease.
Thank you so much, Dr. Yuli, Director Yuli. I think this is great. You've touched on some of the real challenges that you are facing in Indonesia, the double burden of disease, but at the same time, given us a lot of good ideas about going forward. I'm particularly excited about the increased access to screening, your public-private partnerships with the TB care, and so on. These are very, very encouraging. And as a invited fly on the wall in a recent meeting with the minister, I know that you and the minister are working very well at hand to solve some of these problems. But we'll come back to you in a few minutes. I have more questions for you, so thank you very much. Let me let us turn now to Dr. Urban Weber. In the early part of this century, I gave him sort of short shrift on his background, but in the early part of this century, he worked as a leader in HIV prevention, both in Germany and in Russia. I think our paths may have crossed a few times in Moscow in the early part of this century, Dr. Weber. And then since 2003, you've been working with the Global Fund to fight AIDS, TB, and malaria. And you're currently managing grants, prevention and treatment, 3 diseases, an annual budget of 800 million USD. And I know that you're leading a very high impact program on TB. So if I may turn to you with my first question, Dr. Weber, let's focus a bit with your experience on TB care. I think that's been opened up very nicely by Director Yuli Faryanti, but you are heading the High Impact Asia Department in the Global Fund to fight AIDS, TB, and malaria. And so maybe you could expand the scope a bit from Indonesia to the relevance of this region, the relevance of this region relative to the global TB burden. Over to you.
Okay, thank you, Jack, for the questions. And indeed, yes, we were crossing paths back in Moscow in the early years of 2000, 2001. I remember you well. Thank you for the organizers for bringing us here together, because this is actually all relevant what we are talking, and I hope this will be providing some inspiration as we move forward. Now, speaking about the high impact Asia region, it covers 9 countries, and I will name them quickly. So this is Bangladesh, Pakistan, India, Myanmar, Thailand, Cambodia, Vietnam, and then of course also Indonesia and its neighbor, the Philippines. So this region represents 55% of the global tuberculosis burden. So the estimation of the global incidence is around 10 million cases annually, and 5.5 million of these cases or these patients are being found in the region that I was just mentioning which countries they are. So what is happening here, of course, has global significance. And from a global fund perspective, as a donor, the countries in the region cannot be successful in their disease programming, in their global fund disease programming, if they are not successful in addressing the tuberculosis epidemics. So, and this is also highlighted by the fact, if you look at the focus or the concentration of the global fund's tuberculosis investments on a global scale, only 18% or 2.2 billion of 12.6 billion for the current 3 years period are dedicated for tuberculosis, whereas 50% are for HIV and the balance is for malaria. In high impact Asia countries, this is almost inverse when looking at when comparing TB and HIV. Here we have 53% of funding, $1 of $2 billion go into tuberculosis, whereas HIV is only 33 and malaria 14. So this makes it clear and evident that this region is the tuberculosis region, which of course should not make us forget that HIV is a problem in many countries as well. Malaria is less of a problem because it's about the elimination of it. So there we don't have the mass mortality and the mass morbidity that we are observing in other parts of the world. So tuberculosis is the focus. Now, if we look at the achievements of the tuberculosis programming in the last couple of years, then we decided to have a concerted effort, and we decided that not from Geneva, of course, but this was a dialogue with the countries in the region to increase the number of patients that are being treated relative to the incidence that we have in the region. And we took 2015 as the baseline for that. And in 2015, 55% of the patients were notified, which means that just above half of the annual incidence of where patients were actually treated. And we made a concerted effort across all of the countries, and it was, you see the graph here very nicely, that we were bringing by the end of 2019 the treatment coverage to 75%. So on the top right graph, you see the incidence, which stays in the blue bars roughly flat over time. But the orange line is representing the percentage of those patients that have been notified and therefore treated. So notifications increased in absolute terms from a baseline of 2015, which was 3.1 million cases annually, to 2019, 4.1 million cases of patients that were being treated. So an increase of 1 million over the course of 4 years. And this allowed us to first observe also a beginning of a reduction of the mortality. So only 700,000 people in all of the region were dying from tuberculosis as compared to 800,000 4 years earlier. And we were reaching slowly but surely treatment coverage rates, and the expectation would be that we would soon be at 80% and then going close to the gold standard of 90%, so that we would reach a sustained period of time across many countries in the region, essentially all of them, where we could then see an impact of the response to tuberculosis on the incidence itself, so that we would see a decrease in the annual number of people becoming ill from tuberculosis in a way that they would need treatment. And one of the main drivers of success was the expansion of tuberculosis services to include the private healthcare sector, and also starting to increase the primary healthcare sector where this was an opportunity, and at the same time expanding the reach of the national TB programs. So finding missing patients was the catchy slogan that was summarizing these efforts, and which led to a success that has been mirrored nowhere else in the world until today. And with that, back to you, Jack. Thank you.
Thank you very much, Dr. Weber. Very interesting numbers, very hopeful numbers, but at the same time, very disappointing to see the numbers change over just the past couple of years. And of course, when we think about Asia, we think about China, we think about India, we think about Indonesia, each of these countries struggling to solve the TB problem. But at the same time, each of them, I think, have come up with some relatively innovative approaches, and maybe we can come back to that later. Let me move back to Professor Kara Hansen, but I will remind all of our viewers that we will want questions from you. And when you do provide your question, it might be helpful if you tell us who you would like to answer the question. So we may have a lot of good questions, but we won't quite know who to assign them to. So maybe you could just point out, this is a question for Kara, or this is a question for Director Yuli, or this is a director for Dr. Weber. So Professor Kara Hansen, back to my second question for you. We all worry about enough resources. Maybe we could talk a bit about resources and how to harness more resources. You've mentioned this in your early answer. And the Commission, for example, did not propose specific packages, and you mentioned that, but you also recognize that having one that is aligned with fiscal capacity would be important, and that there are different levels of which packages operate. Can you give us some examples of how different countries have used different policy levers to allocate resources to primary healthcare? And of course, I am, as you might expect from me, particularly interested in how provider payment models act as a resource allocation tool. Over to you.
Sorry, thank you, Jack. So the way, as I suggested when I answered your earlier question, I went into this commission really quite naive about how resource allocation works. I thought if you say you need to allocate more resources to PHC, it would be obvious how you do that. But actually, it's not, and it's not partly because PHC isn't, because the budget is the tool through which you allocate resources, and PHC is not often a budget code or a budget line. We tend to allocate resources to different things, none of which is labeled PHC. So what we did was conceptualize 3 sets of policy levers that are available to countries to allocate to PHC. So one is the stage of budget formulation, the second is budget execution, and the third is thinking about service delivery configuration as an allocation tool. So I think that the budget formulation stage it's kind of the obvious one. So a number of countries have moved towards a program budget system where PHC is identified as a program. So in South Africa, for example, there is a PHC program that kind of runs in parallel to the input-based budget, but it allows those resources for PHC to be identified and tracked. But there's a whole bunch of other budget tools that countries have used, some of which you'll be familiar with, Jack. Things like statutory appropriation. So in Nigeria, for example, they have earmarked 1% of general taxation revenue to use for something they call their basic healthcare provision fund. And that really is to strengthen PHC. So you can have a rule that operates, so it kind of gets that budget allocation out of the political domain and into a rule-based domain. The other place that uses an interesting budget tool is India with the National Health Mission, where there are matching rules about the relationship between central government funds and state funds for prioritized services. The second set of tools we thought through were issues around budget execution. And I think that's where it's quite interesting to think of provider payment as a budget execution tool, because different types of provider payment allow money to flow through the system in different ways, and in ways that can be quite distorting of allocations to PHC. So we kind of thought through how, again, linking back to capitation payment, how capitation can act as a way of protecting and ring-fencing funds for PHC, because it's based on population level allocations. It's not dependent on following patients. That's kind of, I guess, one of the worries about systems where money follows patients, is that if patients are then bypassing PHC, the money gets sucked up the system to the hospital level. And so a well-designed capitation system with a budget for capitation is one way of actually allocating resources to PHC and protecting them to make sure they don't drift back up the system. And that's how they do it in Thailand, for example. So the capitation payment for primary healthcare goes to the contracting unit, and it's there as a ring-fenced budget. I think the other thing about thinking about resource allocation as an allocation tool is it doesn't stand on its own. It needs other things to accompany it. So you can't think about how you pay for PHC without thinking about how do you pay for hospital care, because you can create different competing incentives that way. But also, if you are really trying to protect your resources for PHC and drive patients to that level, then you need to think about service configuration, you need to think about referral systems, you need to think about gatekeeping as well. So it's much more complicated than just capitation on its own. The third lever we talked about was service delivery configurations. There's some kind of obvious things there. So one way of pulling money out to the PHC level is to create a new cadre of PHC workers where that's appropriate. So in Turkey, for example, they created family doctors. They created them as a new cadre, and that was able to pull resources to the PHC level. Likewise, in Estonia, that kind of moved from the kind of Samashko kind of polyclinic model to a family doctor model, where the family doctors were paying capitation. But I think there's something else that came out in recent discussions about Mexico. Actually, it's not just having that cadre of delivery people, but also how you set your service delivery standards that matter as well. So decisions about where does TB diagnosis take place, for example? If that is going to be at the hospital level, that is going to certainly move resources to the hospital level. If it's possible to centralize all or part of that function and allocate resources at a lower level, then that's one way of helping to protect resources from getting sucked up to that hospital level. We had two more conclusions. One was that no single policy lever was going to be enough, that countries that have been successful in really concentrating resources on PHC have deployed multiple tools at the same time. So, in Thailand, you've got a capitation-based system, plus you've got a provider payment system for hospitals that reinforces that retention of resources at the PHC level, and you've got a referral system that reinforces that as well. The other, perhaps relevant to Indonesia, is that things are way more complicated in decentralized contexts. That as the center, you may have a policy initiative at the center to increase resources for PHC, but it's much less visible when, or budgets are much less visible when they're happening, when budget allocation decisions are taking place at the decentralized level. And so in decentralized systems where local governments are receiving a block grant, that they're making the decisions to allocate between health and other things, and within health to PHC and other things, then you might need a lot more in the way of policy tools to be able to protect those resources for PHC.
Thank you, Kara. Multiple tools at the same time, music to my ears, because I think that is the way to go. And, if we think about Indonesia, and that is a big part of our audience today, we think that they have to do a number of things. They have to update for inflation. They have to think about the virtual pooling with the district allocations. They have to think about whether they have an adequate cadre of trained people, and then to risk adjust for severity of the population. So I think they are thinking about it in a multiple tools approach as well. And with that, let me turn to Director Ibu Yuli and ask you, during COVID, Director Yuli, what were the good practices in Indonesia in responding to TB from the primary healthcare perspective? You've touched upon the TB issues in your early answer, but this may be this issue of responding to TB may have been around generating resources, as Kara has pointed out, or it may have been around other initiatives, as Urban has pointed out. At the same time, did you have disappointments, and what were the lessons learned? So over to you.
Thank you, Jack. I think I'm interested with the Kara mention with about the more allocation for the primary healthcare. I think it's a lot of funding for this primary healthcare. I want to share one slide. Is this okay, Jack?
Yes, please, please.
Okay, I have. If we talk about the public primary health care, I think especially for the puskesmas, we have purchaser like National Health Insurance, local government, Ministry of Health, household, and the donor. And we have a mechanism for the provider payment. It's like capitation, like Kara said, no, non-capitation, budget, vertical program, sorry, they like user fee, budget, and the others. But it is the existing now. But we still have potential block for this, and we need synergy central until the local government. It is why we have some innovation. We learned from the pandemic COVID. We have some like push to push to increase to decrease about the COVID pandemic with the repurposing and the reallocation budget for the strengthening to the pandemic COVID, like for the test, tracing, and the treatment for the pandemic COVID. Now we talk about this TB. We learned with this. We need a strengthening for the strategic purchasing for the TB. We see about the funding short of the TB, like government budget, national health insurance, in the primary care, referral, lab, and the public program management, in the outpatient, inpatient, for the drug, medical supplement, we have a lot of the government budget, but we need synergy for the all the resource. I think if we talk about a public scheme for the TB expenditure for the national health insurance, central government budget, and the local government budget, here we have we can look proportion and the health expenditure for the TB 2018 until the 2020. It is, I think, in the 2020, in the central government, still more allocation for the TB compared for the local government. Nah, it is why we need synergy to funding source, government and the central. We have some. I think we have some innovation. Oh, oh, wait. Oh, tidak. Oh, I have nothing in here. I will say. We have some allocation for the local government, like the funding for the local, like is it DAO? It's we call DAO, ya, dana allocation umum. It is the specific for the local government. Our innovation, we need some, we have separate for the DAO, for the block grant DAO, and the specific for the specific grant. For the block grant, we just for the operational, just need operational for the primary care. But the specific grant, we need set up for the indicator, like the TB indicator, to make awareness for the local government, for the responsibility for government to decrease prevalence tuberculosis, like this. But now we just discuss, but I think we need some other indicator for the setup to local funding from the local government. It is why we have some innovation for the 2020. But the second, we learn for the strategic health policy, we strengthening to for the TB, but now Usaid help us to decide set up to about the TB, what to buy from the TB, from buy and the other. I think this is for the some innovation to decrease prevalence to TB, even for the strengthening primary healthcare investment. What I said before, the priority program to strengthening routine immunization, early detection, and mother-child health care. This is the early detection expansion, including tuberculosis. And that is public health incentive for the public primary health care. The background about the public health incentive is because the promotive and preventive program is priority, and we have we still have a lack of performance of the public health program. And the third, we have some budget from the transfer fund is like a BOK allocation. We need because we increase in the transfer fund, and it is why we need the public health incentive. For the, I think we no need to talk about how much it is 7.5% or something 10% as like this, but the goal is the public health incentive is to increase performance for the priority program, is including the TB program in here. And the second is for the fairness. Fairness is like puskesmas location, workload, and the puskesmas workers. It is why we we want to know, know about the performance improvement in the promotive and the preventive program implementation. It is why we revised ministerial decree on a special allocation fund in the health for the 2020. It is why I think I stop here, Jack.
Thank you very much, Director Yuli. This is fascinating. You started with the challenge of multiple purchasers, and you finished with your moving towards multiple tools, including incentives and strategic purchasing tools. So that's very exciting. Thank you very much. Dr. Urban, I'm going to move to you. We are fast running out of time. I'm not sure, this will probably be the last question. If we do have time, I would say there's a question in the question box for Kara, if she could answer that. But let's see. Urban, Bu Yuli discussed Indonesia. Maybe you can give us an expanded picture. Certainly, COVID was heavily impacting TB programs in many parts of the world, as you've pointed out. But how did it manifest itself specifically in Asia, in the Asia region? Which countries, how did countries adapt? And what characterizes countries with a faster recovery? Over to you.
Okay, thank you. I think I will run through this response. I mean, first of all, we need to see that it was a drama of epic proportions that was happening because of COVID in the nine countries of high impact Asia. The notification rate declined back down to 55%, where it has been in 2015. So thereby essentially wiping out all progress that has been achieved during a 4 years period between 2016 and 2019. So notifications stopped by 1 million, from 4.1 million to 3.1 million, which means 1 million patient treatment episodes were lost. Without this, we would have been at 80% treatment coverage, but we went down to 55. Now, in 2021, however, we could observe a fairly solid, really a solid trend reversal that we have seen, and the treatment notifications went back up to 3.7 million or 68% in 2021. So there was an increase of 600,000 in 1 year in 2021. However, for the 2 years combined, we lost 1 million in 2020 and 400,000 in 2021. So 1.4 million in the 9 countries, 1.4 million patients that would otherwise have been treated were not treated. Now, still, this increase is really solid and it's broad-based, and we have now even 2 countries that are in 2021 already at or above the levels that they have been in 2019. So these 2 countries are Bangladesh and India. They are the front runners of the recovery efforts. They are now already in the period where they are scaling up rather than just catching up to the pre-COVID levels. They are scaling up beyond what was actually achieved already in 2029. Now, what happened is that the reason for the recovery was, of course, the lifting of the lockdowns. In India had, for instance, a mass migration in 2020 to villages after losing jobs in urban centers, and only after the lockdown ended, the patients could visit the village doctors again, and vice versa. Community health workers could visit patients to bring medicines and ensure adherence. But also, we could see that the capacity and the resilience of the national TB programs, of the lab systems, and of the health facilities was actually higher than we would have expected after the catastrophe of 2020. So the countries were actually adapting to it. So in Indonesia, for instance, started for drug-resistant tuberculosis a multi-month dispensary, which was not the case before. The patients had to come every day to get their medications. But also the home delivery of medications for drug-sensitive tuberculosis was established. And also the sputum collection was based on home delivery rather than making the patients come. In the Philippines, home-based treatment was put in place, and mobile clinics were being rolled out. rollout of all oral treatment regimens, replacing injectables at a large scale. The tuberculosis sputum transportation system were expanded to also include HIV services and not just tuberculosis services. So all things that reasonable people and pragmatic people could have also done without being forced to do so through an external shock, which was the COVID epidemic. But also the private sector and the community engagement was critical. All these countries which are faster in the development have the private sector, have a focus on the private sector and on the communities, and in particular, and this is the last point, and I will close with that remark, where there was a very, very strong political will and a strong leadership in keeping tuberculosis on the agenda, we saw a recovery occurring significantly faster than where this was not the case. And while Indonesia was originally fairly slow in responding to COVID, it was rolling out a massive COVID response, and now is maintaining TB on the agenda and the best example for that is that they are negotiating a loan with the World Bank as we speak in order to increase the fiscal space. So this is a perfect expression of the political will that is required to get back. So now this message is what we are transporting or transmitting to all of the countries, so that we see that we try to create a bit of a healthy competition within the region of high impact Asia, so that the front runners will be seen as those who need to be caught up by all the other countries in the region. And with that, I give it back to you. Thank you.
Great. Thank you so much, Urban. Great answer. A great way to finish. MC Rama, how many seconds do we have left? Do we have any time left at all, or do we need to move on to the next group? You're on mute.
Yeah, I think time is up, sir. So it would be best if we should just end the session right now, perhaps.
Very good. I want to thank our great panelists for their answers, their good answers, their provocations for how we might think about this issue going forward. And we will have, I believe, Dr. Rama, we will have a summary, and we will have some reactions in the next session. So everyone hold on. Thank you again. Over to you.
Okay, thank you so much, Mr. Jack, for conducting the last session of today. It was very insightful and very wonderful. What a way to close the event. Thank you so much. But before we really close the event, we would like to invite the Vice Chair of the Indonesian Health Economists Association to deliver the summary of today's event. Please welcome Mr. Adiatma Siregar. Hello, Pak Adiatma. I think you're still on mute.
Yeah. Can you hear me?
Yeah, loud and clear.
Okay, perfect. Yeah, first of all, I would like to thank the moderators and panelists here for delivering such important subjects and topics today. Much appreciated, and also to the webinar team for delivering a very good job. Yeah. And for the summary, I think the team has done a great job in compiling these points, which is hard, yeah, because we received so many lessons today. But yeah, so these are the points that maybe we can ponder, and then hopefully, of course, it does not cover everything that we learned today, but hopefully it has some, it gives some insights, yeah, of what's been happening today. So as you can, we hear this a couple of times, that the pandemic is still ongoing, and we need to remind ourselves that the pandemic is not yet over. It seems like the end is near, but we must remain vigilant. And at the same time, efforts to achieve USC is still facing an inefficiency in the health system. And if we are going to learn, well, I mean, COVID-19 pandemic has taught us, harshly, the importance of health system preparedness and resilience, yeah, to face public health threats, yeah, and also COVID-19 pandemic also has that large uncertainty, And therefore, we need to develop a unified risk mitigation approach for future pandemics. Yeah, and we need to have greater coordination to enable faster response, which is very important. So opens opportunity for people, to make ideas to improve health system. And in this case, investment in health, public and private, especially primary healthcare, is key. And some examples here, the 1% of GDP allocated to primary healthcare, depending on the priorities. That's this suggestion by WHO. And also, we heard a lot about budget policy relaxation, increasing health budgets, etc. And then building resilient and people-centered primary healthcare also can be done through investing in health workforce in public and private healthcare through providing training, improving capacity of health workforce. So if we go just quickly to the Indonesian case. So we have that increased absorption is also getting better, but at the same time, we need close technical guidelines for implementers. And PFM also needs to be strengthened, and we need to spend more, spend better, and we need to better orchestrate our delivery system and financing systems. Now, globally, we also learn that, pandemics and indeed are a systemic issue, not solely development issues. COVID-19 crisis made it clear, that pandemic policy is economic policy. Both are pretty much very, very much related. And there's also the term wartime financing, so the time value of action enormous, and then the next point is very important. The path of pandemic would have been very different and much less costly if sufficient and timely funding has been made available. So a broader lesson from the pandemic is financing a trade of global public goods, which requires stronger multilateral institutions, equitable ownerships of all and stewardship of global goods, rapid and adequate financing windows for global public goods, diversified supply chains with regional manufacturing. Now, lastly, of course, during the pandemic, other diseases also emerge, also keep on going, and then TB has been impacted very harshly as well. In 2020, bringing coverage back to 2015 levels, and now we are fighting to go back to at least in the area pre-2020. Therefore, comprehensive and sustainable resources allocation is needed to ensure that future pandemics will not diminish essential care coverage. Okay, and with that, I return the session to Pak Rama. Thank you very much.
Thank you so much, Pak Adi, for delivering the conclusion for the first day of our webinar. So, ladies and gentlemen, we have arrived at the end of today's webinar. We would like to thank all of the speakers, our moderators, as well as all participants for joining us tonight. Before we close the event, we would like to invite all participants to come and join the second day of this webinar, which will be held tomorrow. We also would like to share about our future events. Our nearest event will be held on August 2nd, which will discuss about Policy Area 2, about the Airborne Infection Defense Platform, and on August 4th, which will discuss about the Policy Area 1, equitable access and production of diagnostics, therapeutics, and vaccines to confront COVID-19 globally. For more information about our events, the T20 events, please visit our website on t20indonesia.org. Ladies and gentlemen, once again, we would like to ask all participants to fill in the attendance form and the evaluation form, which has been sent in the chat box. And also, we have sent you the link to download today's materials. So please visit the link that is shown on the screen if you plan to download the materials. So my name is Rizky Ramadan. Thank you so much and see you tomorrow at the second day of the T20 webinar, Putting People at the Center of the Health System. Thank you. Terima kasih. Have a good day, everyone.